E o ngā manoha, tēnei te whakamui mea tutu ki a koe mō tēnei huhui ngā mātou. Arahina mai ki a au ki te tika, ki te ponu a mātou, tuko mai tō wairua tapu hei manaki, hei awhi hei te aki hoki a mātou. Anei mātou e tuohu nei mui tō aruaru, a ka tuku I tēnei ino, I runga I te ngō tō mātou kai whakuara I Ukraiti. Āmini.
Āmini, kia ora e hoa.
Kia ora.
O morena tātou, tēnei te mihi atu kia koutou, kia tātou katoa, mō tēnei hui puari. Warm greetings everybody, and excuse me, also to everyone who is joining us on the live stream. Welcome, and it's good to have you with us again today. We don't have a huge agenda today, so I am expecting that we should be finished at around our anticipated time of sort of 12 to 12:30. So we will get underway. We have apologies today from Gavin and Sandra.
I'll just come over there, but there we are.
And I think that's all we have. Anyone from your end, Jim?
Anil is on leave today.
Okay. Well, I hope he has a wonderful day. We move to item 2.1, which is our schedule of interests on page 3. Does anyone have any additional interests or changes? No, or any conflicts in relation to agenda items? Carl? Okay, so item 3.1 is our previous minutes from the 29th of March, which are on page 7. Does anyone have any amendments to the minutes? Matters arising? Okay, so we will receive and adopt the minutes. Any action items? Sorry, I'm just pulling up my papers. Were there any action items? I don't think that we were there.
No.
Okay, so we'll move on to, there's no correspondence in this part of the meeting, to the performance dashboard on page 12 of the board pack. Jim, if I can pass to you, if there's any matters that you'd like to highlight through the performance dashboard.
Just that continuing issue, that problem that we've got around childhood immunisations, and to note that on behalf of Iwi Tūranga Health are taking a lead around a campaign that we can be running in the coming months around all forms of immunisational vaccinations, and definitely need some extra work going on in that area. So keen to see building on the work that has been done around the COVID vaccinations, what we can learn from that and apply to this situation around childhood immunisations. But also there is the campaign that is out there around 15 to 30-year-olds. I think that's the right age range for measles vaccinations, or measles, mumps and rubella vaccinations, and the sustained effort we need to have around this winter for immunisation vaccination for influenza.
Thank you, Jim. Does anyone have any questions on the performance dashboard? Heather.
Only, as mentioned at FRAC, the staff injuries don't match the data that Amelia gave at FRAC last week. So there were needle stick injuries and violence towards staff. But I think it's getting better next month.
Thank you, Heather. Okay.
Morena. Jim, on page 13, top of the page, is the faster cancer treatment rate. Is that due to COVID? It's dropped to 40%.
Unfortunately, Hiki, I did notice that myself as well. Unfortunately, I don't have the absolute details about that. In my report, it gives the actual numbers, but I don't know the what happened with those other cases. I'd be surprised if it was COVID.
Can we maybe pick that up as in a matter arising for next board meeting, just so that we can get ourselves clear on that?
Yeah, we just haven't had our review meeting of those missed opportunities, so I can't give you any further details at present.
Why, thank you. Andy.
Yeah, thanks, Jim. Just back to immunisations. There was a bit of noise this week about meningococcal vaccination in the young adults. Where do we sit with that?
I'm going to have to pass on the definitive details around that, unless Ian or Aria, Ian might know. Have you got any details on that, Ian?
Not off the top of my hand, but it is part of the. No, not off the top of my head. Sorry. I will look into it.
Thank you.
Any other queries on the performance dashboard? I guess the drop off on some of those performance indicators are no doubt a result of the pandemic, though, Jim.
Yes, definitely. Yeah.
And it's a nationwide phenomenon that's happening with reduced clinics and whatnot.
Yeah, you'll see that later in the coverage around our planned care statistics, showing that period of time last month where we had a reduction in planned care, for instance, and same things happen with many of these statistics as well.
Thank you. Okay, if there's no further discussion on the performance dashboard, our thanks to the staff for that, and we'll move on to our regular reports. So from me, it's actually been a reasonably quiet month on all things considered. Te Manawa met in early April and meets again next week. Next week, we will be having the chairs of Interim Health New Zealand and Māori Health Authority joining the meeting, so that they can start to get a feel for Te Manawa as a region. But I do think it's really important to note that our region has actually got a fair amount of representation on those boards, with 3 of our Te Manawa chairs, 2 current and 1 past, on Health New Zealand, and also 1 past chair is co-chair of the Māori Health Authority. So, overall they'll have a pretty good feel for Te Manawa as a region. Rotapura met, I think it was just last week, Jim, and Jim provided a great presentation on the COVID surge, our current status and modelling going forward. So no doubt we'll be discussing that a bit later in the agenda. National chairs are not meeting again until the 12th of May, although we do continue to have fortnightly updates with the Minister. And, to be honest, they've pretty much been focused on the pandemic, winter planning, regional collaboration, ensuring that we, continue to focus on business as usual as we lead into the reforms. Always a very strong focus on ensuring we maintain strong financial disciplines, and more recently, industrial relations matters. We are working with Health Share and Health New Zealand particularly on actions that need to be taken prior to handover. So we had a bit of a discussion at FRAC on this last week, and that'll be something that will, start to make sure that all of the detailed actions that need to occur for the transition happen in good time. And Nara and I continue to co-chair Te Manawa through until the end of June, and that's good. Te Manawa are very works really closely together and has really strong relationships, so that will stand things in good stead going forward. So that's about all from me at this point, unless anyone's got any questions. No. Okay, then I'll hand over to, oh, sorry, Tony, I didn't see you there.
I was trying to wave as hard as I could. Look, leading into the new health entity, and of course, one of the benefits, proposed benefits of it is that specialists can't shop around. Are we getting any obvious signs of people trying to shore up contracts, or, you know, I'm just thinking of our ongoing challenge with specialists and outsourcing. Is there any sort of obvious movement in the medical staff sector in anticipation of what's coming?
Not that I'm seeing. All staff will lift and shift into Health New Zealand, with the exception of chief executives, but chief executives will carry on to help post 30 June for the transition. Jim, do you have any insights into Tony's question?
I don't see anything that you're describing, Tony. I think it's very early days, and there is more information coming out around Health New Zealand. We're expecting tomorrow, so that might provide more detail around people could be making decisions around. But that's tomorrow.
Okay. All right, I'll pass over to Nga for the report from the chair of Te Wairua and Taimi Meha.
Thank you, Kim. E te tūru ngā mihi nui ki a koe. Tātou katoa e te pōre matua, kei te mihi tēnei. Mō o tēnei rā whakamaumahara mō rātou. So, yes, T1 meeting last night, bit of a hitch. There were different Zoom numbers and dialing in, so we actually didn't make a quorum at our last week. First time in years that's happened, technical reasons. But just to say, there were no decision items on that at our last meeting, so that was fine. We continued on with the meeting. But we had the diabetes action plan, which of course we supported. And a couple of points I just wanted to make was the addressing the intergenerational and gestational diabetes issues. Those were quite prevalent in that plan. We're very supportive of that, and of course the overall pie order, healthy futures outlook for the diabetes plan as well. So we're quite pleased, and we liked the coverage, particularly the examples that we used towards the start of the plan. There were Māori, Pākehā, youth, elderly. It really showed the impact of diabetes across the whole population, rather than, particularly in our case for Māori, but simply that it does affect a wider range of people. So there's a lot more going on in our community with that respect. There are a couple of papers that did come to us, and I see them on the agenda today. So I'll speak to those when we get to them, except to say that the Toi 2 one is on the agenda as well. So I'll speak to those when they come up on the agenda, madam.
Thank you. Does anyone have any questions of Nga?
Cool.
Okay, then we will move on to the Chief Executive's report, which is at page 14 in our board packs.
Thank you, Kim. This month was another one of where we've had a better than budgeted financial result, and that is in accordance with the additional revenue that we have seen this month, or have put in place this month for COVID expenditure that we've had in prior months, and so that has helped us there. And also we have that money that we phased out in the first quarter coming back in these last 6 months of the year, and still around about, I think it's about $900,000. Kath will correct me if I'm incorrect around that. That still needs to come in those last 3 months of the year. So Kath will talk in her report coming up around our financial projections until the year end, but we are heading in the right direction at present. You will see there that we had quite a pronounced lower numbers of people acutely admitted to the hospital in last month, and that is we're on a little bit of a downward trend at present. Some of that will be related to what happened in lockdown period, not that we've had lockdown, but lockdown period where people haven't come to hospital as much, and so that means that the pressure was off. But we did downscale our planned care services, as I said just a short time ago, to enable us to be prepared should the numbers of people come through from the COVID in the community at present. And I'll give an update on that, on the COVID situation shortly as well. But in general, yes, the numbers of acute admissions down, and particularly for our paediatric population on the bottom of page 16, and really pleasing to see some of those statistics across there, although there is, of course, concern, and I know we talked about cancer previously, but for instance, the Cancer Control Agency looking at whether there are any long-term repercussions for our population in lower reporting of and lower people coming forward because of concerns about coming out into the community currently with COVID circulating. I think that's pretty much the highlights there. As I've said, we are very concerned around our immunisation rates and the effort that needs to happen there, while we've got some measures in place, such as that work that's currently going on between our outreach immunisation service and Tūnanga Health. That still means that we need to put in more effort around getting better results for that. The planned care production on page 20, you will see there that we slipped behind a little bit further around planned care, both for people waiting longer than 4 months for a first specialist assessment and for treatment in that month, which was an expected outcome of the fact that we only, for about a period of about 3 weeks, only were responding to people with faster cancer treatment pathway and people who were P1 and could not wait at all, because of the need to avoid surgery and anesthesia for around the period of time that people may be exposed to the virus. And so now we have to gear up again to get back into that. You're seeing on page 21 there a number of services that are experiencing this, and this is going to be a problem to manage over the next few months. It'll be winter. There'll still be COVID circulating in the community. We've got a large proportion of staff with increasing leave liabilities and people who just haven't been able to get a decent holiday for a couple of years. As you know, we have a number of our staff who have links back to countries overseas and who haven't been able to see their whānau for some period of time, and are very, very keen to catch up again now that our borders are opening again. So we're going to have to manage all of those things through over the next few months, and you can see already that a number of our specialty areas are experiencing those pressures, in part because of that. So that's both in terms of SB2, that's first specialist assessments, and SB5, which is for treatment. Happy to take questions on those. Yeah, I think that's just checking through to see if there's anything else that I can think of that I just need to raise. I'll take your questions first, Tony, and then I'll come back to my discussion points.
Thanks, Jim. So looking at page 21, for example, urology, why does the planned number bottom out at 0? Well, actually, all of them. Why does it bottom out at 0 whilst the actual goes off the Richter scale? What does that mean? That we've got no planned we've got no planned cardiology, we've got no planned urology.
So those tables, you're talking about the ones with the red and the green on them?
Yes.
Yeah, those tables are the ones which were our planning for this year. That's around people waiting longer than 4 months for either a first specialist assessment or treatment.
All right.
So the plan was to have nobody waiting longer, but in fact, for urology, I think it's SB5, there is 4 people at the end of April, but longer than 4 months. Yeah.
Okay, so why has cardiology gone off the scale?
One of our cardiologists is in the UK.
But permanently or on leave? Or
No, on leave. On leave. Yeah, that's why I specifically made that mention around that we have got difficulties at times because we're needing to accommodate the needs of people needing their appointments and also the needs of our staff to get leave.
Yeah, and are we any closer to filling a urologist position?
We have got better coverage now with our visiting specialists in relationship to urology, and we have been looking at a possibility of 2 different people to be interviewed to be appointed here. Neither of those have come to fruition in terms of having somebody appointed here yet, but we definitely have better opportunities there now and better coverage remotely from our visiting specialists.
Right. So Jim, sorry, just one last question. Are you indicating that there will still be specialists seeking leave and potentially overseas travel, so that therefore after April these numbers are potentially not going to improve in some areas or get significantly worse in some areas? Like if a major person drops out of neurology or gynecology, are we going to then be just seeing a repeat of this table for the next 6 months?
What I'm signaling is that some of the increases that you're seeing in some of the red on those tables is because of the fact that we've deliberately not been providing plan care services during this current period of time. So that's got worse because of that. But I'm also signaling that winter is always a more difficult time for plan care because of when you get increasing numbers of people acutely within the hospital, we sometimes have to pull back on planned care in those circumstances to make sure we've got the coverage. And then on top of that, I'm signaling that we've got the situation where we do have to accommodate and try our best to accommodate the needs of staff to get their leave and their breaks at the same time as dealing to those numbers of people who are waiting for their treatment or their first specialist assessment. So I'm not saying across the board, but we will see these figures move and get worse at times and better at times as a result of that over the coming months.
Thank you.
It won't be a complete, charge towards green.
You'll recall, Tony, that we have asked Jim to prepare a report on really on staffing pressures and vacancies. Jim and I discussed that earlier this month, and because people are actually away at the moment, the board will be getting it next month. But I think that'll be really timely as part of our hand into Health New Zealand, so that they have a very current snapshot of where our staffing pressures are. Hickey.
Kia ora, Kim. I've got 2 questions. The first relates to how are our iwi providers managing, if this is happening with Hauora Tairāwhiti, in terms of their capacity and workforce. Is there anything we need to be aware of, any support that needs to be offered, or whatever? That's my first question. Thank you.
They're facing similar problems, although they tend sometimes, particularly around registered nurses, the same as we are around registered nurses and registered nurses with specialist skills. And I would extend that also to residential care facilities, where they have a particular hole at present around numbers of people, registered nurses there, and they have had a traditional pipeline of people coming from overseas to join their staff, and that has been closed off for a period of time, well, not completely, but severely restricted for a period of time. So they are feeling that. What we have seen with the iwi providers and for our own organisation as well, and you'll recall that the iwi providers took on an extra 30 people over the COVID period. Those were not formally qualified people with a health qualification, but have been invaluable in the work that they have done over this period of time. And those 30 people will continue on in those roles and support them. And similarly, as DHB, we've taken on 30 as well to support our role, to support our clinicians to practice at top of scope by being able to fill in those roles and parts of jobs that can be done by people without a formal qualification. So that's happened both within EB providers and within the DHB, and we see that as a way of being able to maximise the amount of skill and work of the clinical staff, and at the same time providing developmental opportunities for those people, invariably most often younger people, and giving them opportunity to move on to health careers.
Thanks, Jim. I think in our community particularly, we're hearing stories of volunteers who were helping with the lockdown, then the floods have now come down with COVID, and so the capacity to meet some of the needs of the community are really stretched. So that was my first question. The second one relates to a comment on page 27 under the population health relating to rheumatic fever agreement. Can someone update us on what is the situation around this agreement and what's the status of rheumatic fever in our rohe, please?
Ian, that sounds like you.
Absolutely. The Ministry are pulling a smaller part of the rheumatic fever agreement. They split it between healthy housing and rheumatic fever. The part that they are looking to pull is the part that we utilise for our swabbing within primary care for strep A. It's a small component of the agreement, and we've built a budget in for that funding the service for next year. There was just notification that the Ministry have officially pulled that funding. Rheumatic fever, last year we had 0 cases, and I believe that we've had 1 instance of rheumatic fever. I'm not sure if it's a new case or if it was an existing case this year.
Thank you. And so who will be doing the swabbing? Will that go to primary health?
The swabbing will remain within primary health at this time.
And I know that with all the things that whānau have to worry about, this is another important thing for them to perhaps understand, and also perhaps for primary health, because can people get in to see their GP with a face-to-face wanting to swab, or is having a sore throat one of the indicators for COVID and therefore they can't get to see their GP?
To our knowledge, they can get in to see their GP. The GP practices have what they call red zone set up, and during even the COVID surge, they were very, very communicative to their whānau, to their enrolled whānaus, to advise, please come in, even for sore throat. Even if you had COVID, they would still see you. So yes, they're very proactive in that space.
And so would the test for strep throat be one of those they would automatically do, or not necessarily?
Not necessarily. Depending on symptoms and presentation, they may just, but for sore throat alone, yes, they would. It depends on the clinician and whom you're seeing and what their standing orders are.
Great, thank you. Kia ora.
I'll just come back to a few that I put at the end of my report there around discussion topics, just to advise the board that that WorkSafe compliance notice that we had around that assault that occurred in the mental health facility over 12 months ago now, that the WorkSafe has now removed that advice notice, and as a result of the work that's been done both by the team within mental health and more across the whole organisation, but we'll need to keep that up, of course, over that time. But they advised us formally last month that had been completed now. Just on the clinical leadership front, we have got all of those additional roles in medical clinical leadership in place now, and are moving on to recruit some further people into our quality team, so that we've got much better coverage around that. Plan care we've talked about, vaccination we've talked about, rapid antigen testing. We have got a basic service available around collection of rapid antigen tests at present. The numbers of people requesting those has dropped very considerably. And so we've got a range of outlets where people can get them, and also been advising people just to come in and get some to stock up so that they're ready for long weekends and things like that. So they've got them on hand and don't need to wait for symptoms to be able to get. So we've got vast supplies available, so no need to be hoarding them. Managed isolation, sorry?
Jim, is there a charge? How are we distributing those to the public, the rats?
They're free.
So what people can just come into where? Or where do they collect them from?
They can still collect them from the railway station as an option, and add over it to Tairāwhiti as an option, but also all of our all the general practices have them available to give away to people, and at vaccination events we're also giving away boxes of them as well.
Thank you.
Supported isolation and quarantine SIQ, we've got a very much lower utilisation of that, and our vans, I can see 1, 2, 3, 4, 5, 6 vans sitting in our car park. So that means all 6 of them of our vans are not in use at present, and our on-site flats utilisation has dropped considerably as well. Iwi still have vans through Ministry of MB available as well. So and then there's the Tukuri option as well. So we're doing all right on SIQ utilisation at present. And Tony's got another question.
I do. It's a terrible one to raise, but I was questioned in the community recently around deaths in Tairāwhiti, COVID-related passings. Can you just give us an update at the appropriate time on that, please?
Yeah, will do. So yes, COVID in community. Well, let's start with deaths. So 6 people in Tairāwhiti have died with COVID or of COVID since the outbreak began in January. 4 of those people have been residents of residential care, and 2 people have died in the community. We have details on every single person, and remember that the ministry's definition is a person who has died and has tested positive for COVID within 28 days of that death. So that captures quite a range of people, and in varying circumstances. The majority of those deaths are people with COVID rather than of COVID. So just to bear that in mind.
Rob.
Can we just get the ethnicity breakdown? Thanks, Jim.
I was about to go. I can get that for you probably before the end of the meeting, but yeah, I couldn't do it quite off the top of my head. The mental health. Takatū. The currently demand for services through that is reducing as the numbers of people in the community are reducing, and I'm going to give an update about that shortly. But just to note that for Takatū, that they have very much engaged. There's been agreement from the partners there that there needs to be an ongoing. We can't scale that down to 0 at present. We still need to keep that going. We need to be working with the iwi partners in particular. Iwi are still seeing a lot of pressure that's been exacerbated by the floods and just general pressures within the communities. I know that, for instance, the meals that iwi have been providing 55,000, I heard this morning, meals out of a 70,000 contract, and for those, and need to see how that can be carried forward because of the pressures in the community at present, and also our concerns around resurgence later, and I'll talk about that. Mental health and addictions facility. I think that the figures around about 50%, Kath, of the design of that completed, and so that is progressing. The Child and Youth Hub, we've been able to select an architectural firm for that, and there'll be a discussion about that later in the meeting. Recruitment, Kim mentioned the paper around current staffing pressures, but we are seeing some good appointments now to a number of key roles, but still, still issues around areas like nursing. Industrial relations, you will have heard possibly that there is a industrial action planned by the PSA in regards to their members of who are employed under the Allied Health and Technical Collective Employment Agreement. The negotiations with that have not progressed to a point of satisfaction for the members of that union, and so there is a notice for work to rule from the 9th of May for 2 weeks, pretty much, and so that's work to rule. So that's completely abiding by the terms of the collective agreement. So ensuring they get their meal breaks on time and not working beyond work hours. So we've got planning around that, and Carl's been leading it. Thank you, Carl. And also we are expecting to get strike notice this week as well for a 24-hour strike on the 16th of May, which will also require some quite considerable preparation around that, which Carl has been leading, and we've already got the rudiments of a life-preserving services agreement with the PSA for that period of time, but considerable disruption from that strike with the significance of this workforce to the operation of the DHB. Andy, did you have a question?
Yeah, thanks. It was back on recruitment. Just out of curiosity, I'm not looking for a job or anything, but I went in to have a look at these staff advertising for recruitment, and I just felt as an outside impression that it looked very generic. It was like a list of we need nurses and we need them in a whole big bullet point of positions, rather than making specific positions attractive to outsiders. I assume you get that better description as you go back in there, but it's that first hook, getting people in there. I just felt that perhaps it could be done in a way that was going to lead into more people inquiring a bit deeper. But yeah, it just seemed to be very generic. We need nurses and we need them everywhere.
Yeah. So that's good feedback. Thank you. That's also, of course, been provided by a number of other people. So we're just revising our program around that. That was without preempting next month's paper. One of the things that we were experiencing was that when we had very specific advertising, that we were also getting feedback that people who had generalist skills weren't applying because they're thinking you only want very specific people. That's not me, so I'm not applying. And then we were getting people interviewed 4 or 5 different times for roles. So we tried to coordinate it, and now we're going back to making it more specific. So there's a happy medium there. That's where we're heading to. Right. That was vaccine mandates. We are expecting a requirement for offering, I would say, of a 4th dose of the vaccine for health workers and other people within the community, older people and people with long-term health conditions. No decision yet from the Ministry of Health or recommendation to the government has come out yet. But we do expect that to be coming through. Don't expect that to be mandated though, just an opportunity for that. The oxygen and environmental work is progressing. I know that we are expecting phase 1 to be completed in May and then move on to phase 2, and have got that work going on to get that agreed with the Health Infrastructure Unit. They're now part of Health New Zealand, and get that work completed. Site reconfiguration work, you will see that there's a paper on the board's agenda later on around the electrical work on site, which is a major part of that $6 million of expenditure. Recovery planning, we've talked about in relationship to planned care. The ED facility is one of those oxygen and environmental areas, and our new building is in use now. at the front of the emergency department, front and side of the emergency department. The generator and electrical upgrade is also what I've just mentioned. Reforms, as I said, there will be some announcements around, more public announcements around the reforms and structures, etc., expected for tomorrow. And we definitely now have confirmation of the additional funding available for increase in staffing within the intensive care unit, both nursing and medical. And we are probably not this week, but next week, interviewing for an intensivist role for there, if we haven't already done them, and expect to have that appointment soon. That will be a new era for our intensive care unit, with having an intensivist there. Not on that list, but should be added, is winter planning, and we have much the same as we did for our COVID and the community planning. We've got a ministry running an assessment program for DHBs around that, about their plans, their winter plans, and we've got to have that a questionnaire filled out by Friday, signed off by the chief executive, and we've got a workshop tomorrow just to run through to make sure we've got all the aspects of that, of the expectations around that in place. More a case of translating what we're already doing into the format that the ministry requires. For that, that's my update, and I'll talk about COVID itself a little bit later on the agenda.
Does anyone have any further questions of Jim? No, thank you, Jim. And once again, a very comprehensive report that's really giving us and the public a good feel for the breadth of work that's going on. So thank you to you and to all of our team. Carl, I just I noticed that your microphone was on and then off, and I was wondering if you had wanted to make any additional comment on the industrial relations matter and the preparation for it.
Just preempting, Jim covered, I did give him an update earlier, just to say that we may be receiving further strike notice today. So if that is the case, then that kind of just puts in the wheels in motion to just try and get some more of those things kind of sorted. There's also still the potential of further facilitation. So we always live in hope that we don't go through industrial action, but we are prepared nonetheless.
Okay, thank you. Okay, so we will move on to you, Kath, for the financial report at page 29 in our pack. And in talking about the financial report, can you also talk again with us about the forecast going forward to the end of the year?
As usual, I'll take the report as read. We're seeing the same sort of transactions and trends running through the accounts. Differences this month, we see a swing between funder arm and provider arm in the recognition of COVID costs. So that'll explain their variances. As Jim's already alluded to, salary costs are under budget for the period, so we are seeing, starting to see the impact of the loading of the budget towards these last 6 months. And we still have $933,000 to release in the last quarter. Other items running through the report, there's a significant amount of outsourced running through this period. The vast majority of it relates to COVID activities. 1.49 million of those outsourced costs are COVID related. And we continue to see heavy expenditure in utilities and their capital charge. CapEx is close to the depreciated amount that we have allowed for this year, but we should be all right to year end. Forecast to year end has moved slightly but it's still under 100,000. Again, it's based purely on extrapolated figures. At this point, there are no known figures that would affect that, no known impacts on those figures at this point. I'll take any questions if anybody's got them.
Does anyone have any questions of Kath? Well, I want to very much say thank you to you and Jim on the finances. You know, over the term of the board, we've seen you know, getting closer and closer to budget, and this year is looking like you know, really good. We're going to be all things continuing as planned within a whisker of it. So that's really good news. Okay, moving on to item 6.6, board subcommittee reports. There were no items to bring through in this stage, but I will just pass to Josh and Heather as the chairs of committees if there are any matters you wish to raise.
I'll speak to the next paper because that came. I'm happy to lead the kōrero on that paper because that came from my committee.
Ka pai. Heather, anything that you wanted to raise from the FRAC committee?
Only the late agenda item, but I'm not sure if that's open or closed, probably in the closed.
We've got that in the closed session. Also, just while we're on committees, just a reminder that next month is the last committee meetings, and the June committees, that business will be brought directly to the board so that we're not leaving any sort of hangover items in July. So so next month is the last meeting for committees. Oh, no, yes. Except Te Wairua Nukutaimi Miha, which is meeting in June. Okay, so Josh, then I'll pass to you to lead the item on the National Travel Assistance and Accommodation Supplement, as this has come through from Hiwi Te.
Thank you very much, Madam Chair. Yeah, at our committee meeting, at Hiwi Te committee meeting, this paper had come to us, and we actually felt that it was really important for this paper to be at the board, on the board agenda, and also in public, because it highlights a big discrepancy between how much we're funded for in regards to accommodation supplement and how much what the gap is for whānau. You know, so we thought that this was really important to bring it to us here, and also in the public agenda. I mean, under the financials at the end there, it says that the savings for whānau are between 35 and 50K, you know, and which is great for whānau. But if we flip that around on its head, and if we weren't supplying, we weren't filling in that gap for the accommodation supplement for whānau, that's how much whānau would be paying for over and above the funding that we're providing. So yeah, I mean, moving forward into this whole next Health New Zealand iteration of health services, really feel that this was important to get on this agenda, because the whole the conversations and the whole point between myself, the chair of our committee, so Kim, and also Heather, is for us to kind of collate these issues of things in order to be able to structure up something to be able to hand over to Health New Zealand. So it was super important to have this here. Happy to answer any questions or anything like that. I'll hand the reins back over to yourself, Madam Chair.
Kia ora, Josh, and yeah, just underlining that Hiwi Te Rangi, we're very pleased to receive this paper. Does anyone have any questions or comments that you would like to make? No? Okay, then I think our next item is a verbal COVID update from you, Jim.
Yes, absolutely, Ian. I'm just sharing that with with you at present should be able to see that. So here is our latest graph of numbers of cases within the community. And you will see that we had that very steep rise up the left-hand side of that graph as you're looking at it, and then a much smooth, quite a steep side down this side. This side, of course, was accentuated by our move to utilisation of rapid antigen testing around about this point here. So that really caused that very significant rise. We peaked out at that day there, which was a real peak. That would have been a Monday, and it was a Tuesday, I should say, but a Monday's numbers of cases, and that was at a rate which was similar to that peak seen around the country. So roughly around about 900 cases per 100,000 population, which is what has been seen in Auckland and now in Canterbury. And then on this other side here, as predicted, this slope is not so extreme coming down, and you've got that very nicely patterned Monday effect of numbers of cases highest on a Monday, reported cases highest on a Monday as people return to work and return to school and test before doing so. And then that's nicely, and then interesting last week where the holiday weekend, the Easter weekend was saw some very low reporting, and then a bit of a bounce back in the week after that, and then over this last weekend again dropping away again. So it'll be interesting to see if we get another bounce back this week. And as a result of that bounce back there, in the middle of the week there, the 7-day moving average rose up above that trend line, but is heading back down again now. But that was also seen in the country, and we'll see where that goes in the coming weeks about whether that is the flatter part of the graph that we can see from now on, and I will show that shortly. These graphs don't really change much on a week-by-week basis or even month-by-month basis. So same picture of the most amount of cases in our younger population, reported cases, I need to keep saying, and then down to very few cases for our older population. And that's a bar graph, and here you have it by actual ages, and you can see exactly the same picture there. A little bit of variation between ages, but pretty much the same thing. This left shift of numbers of cases reported within the community. And when you look at that by gender, more women or females are reporting than males. We won't go into debate about why that may be, but yep, that's the actual reality of that. From an ethnicity point of view, you've got Māori reporting more than other population groups, and when you do the mathematics around that, you'll find that 60% of reported cases identify as Māori, and that is almost exactly the population. If you have this population distribution within our population within Tairāwhiti, you will find that that population distribution is 60% Māori, so in line with that. And the only one within this that is is slightly different, is slightly more Pasifika reporting than and then proportion of population, but that is actually evening out now that that things are going on with the pandemic. Modelling. This graph here shows the original modelling that we had. This is our National Support Service for DHB's TAS modelling, which had us peaking out around about that 250 cases per day at the middle of that. But as we saw, we managed to get up to 450. And this modelling was done without there being rat testing available in the community, so much higher numbers of reported cases because of the availability of easy testing within the community. So we picked out higher, and the peak came a little bit later than was originally in the modelling, so it took a little bit longer to develop, but we got up there much higher peak. And you can see, as you saw in that first graph there, just nicely dropping away. This is from their modelling, and they wouldn't have got down to the rate we're seeing here now, around about that 50 cases a day point. So definitely still on that track. Nationally, very much a similar position, although you will see that nationally the total numbers of cases are on the mark for the modelling, and but that same very much a seesaw pattern of Mondays to Sundays along that, but with a downward track and a wider curve on the right hand side of the graph compared to the left. For hospitalizations, we have this picture here, which you can see that we've tracked all along for hospitalizations in Tairāwhiti below the low modelling. And today we have one person in hospital, so around about at this point here. Last week, a couple of days, we had none. And so we are definitely on the trail of coming down the other side of that graph with a much lower peak. This is a bit of a Tairāwhiti phenomenon, that we've had definitely high rates of COVID in the community, and still do. We have had and now around 20% of the population have tested positive and reported that. We believe that is, as we know, is an underestimate, and could be up to double that. Numbers of people who've actually tested, who've had it, haven't tested because they have been very mild, or have chosen not to test, and then or who have tested and have tested positive but have chosen not to report. And so we've looked at some of the reasons, or analysed what maybe some of the reasons why we have that dichotomy of above expected numbers of people positive and well below expected numbers of people hospitalised. And while we know that, as was talked about before, some people will have been managed at home, it's still a good, strong indicator of the ability of the amount of disease within the community, people who get so sick that they need to be hospitalised. So we went through and just had a look at a few of the reasons why we thought. We know that there is really strong cohesiveness within our community, particularly around leadership from iwi and our health providers supporting the community. We have very good reports around people being supported and being able to stay at home through their illness. We had pretty good compliance with source control. So while we haven't all been wearing our masks when we should be, we're pretty much pretty hot on that as a community, and that has protected us and controlled the spread within the community, particularly for our Pakeke, our elderly. Our vaccination rates are comparatively high, particularly for Māori, and that is as a result of the efforts put in by iwi and our iwi health providers to make that a thing and make that happen, and work with the whānau to achieve that. The pathway of care we've had around Takatū, and the partnership with iwi around support for people in the community, as I said before, has meant that people have been able to be in the community, to take off time off work or school and be supported for that time, which has been successful in being able to control the spread within the community. The primary care has been a very key feature. They have mobilised and really come to the party in being able to work with their enrolled populations and those people not enrolled by providing that support both within their practices and within our team at Takatū, where we've got some clinical support within that team there at Takatū. Definitely leaning in. Everybody has approached this with a view, how can we help? How can we make sure that our whānau are protected, and if they do become positive, how are they supported to avoid both clinically and socially? And our colleagues at MSD have been very, very responsive in that as well. Whānau and iwi planning has been a really massive feature, and I know that a lot of work is still being built around that now. Just hearing around, for instance, the the placing of containers at Marae so that there is resources for events such as these and the flooding events, so that there's food and other resources always available to be utilised should these sorts of events occur, either very acute ones, as in flooding, or longer term events, as in the pandemic. And even with our Matakawa whānau getting a national award for their responsiveness is another example of things Tairāwhiti that maybe not the case so much around the country. We are grateful to our whānau in Auckland, Tamaki Makaurau, for shouldering the burden of the outbreak at the start, and through their sometimes some of their not so good situations, giving us time to learn from those and enable us to be better able to respond. Our own emergency department has been a very key feature and mentioned many times, from their backup there, being able to respond and test people and manage the care of people and enable those people to not be hospitalised but to be able to go home again with the care packs and the plans put in place for that. And we have flooded the community with rats and also supported people able to test, and that has meant that people have had much more clarity and certainty around COVID, and given them confidence to be able to manage that within their own homes. So those are just a few of the points that we felt were relevant. And I know that there's a piece of work that is going on to just look at the Tairāwhiti response for future work and understanding around how do you manage a pandemic, but also how do you manage major events and enable the community to come through them. Just moving on, just wanted to give you a bit of a picture around what's happening in the country compared to other countries, this being Australia and states of Australia, about where we are at. This standardizes the start point for all of the states as they had different. You can see there, ours officially started on 28th of January, but the Australian states all started back in December 2021. But if you standardize that, you can see that we have had a peak in cases in this country similar to, I think that is Victoria. No, Queensland. And we've got a much longer tail there compared to those Australian states, possibly because of the availability that we have within our community of testing and more people out there still testing and posting up their results. But note here the resurgence that has been in Australia at present, and that scale there is adjusted, so they've seen their resurgence a little bit earlier, but we could be expecting a resurgence around about that time there in May, and that's why the last week's higher numbers of cases in midweek has caused some speculation about whether that is an example of resurgence occurring. But we will see about that. Part of the resurgence in Australia is because their initial outbreak was not the BA2 variant, which is what we have had in Tairāwhiti, which is much more contagious. And so that may be, and certainly in other countries, that is what they are experiencing there. For instance, in this graph here, where you've got, this is number of daily infections there, and you can see that in South Korea and in Hong Kong, they've had huge spikes in this current round, probably the BA2 variant circulating within those communities, whereas for New Zealand and Australia, we are in this lower pattern here. And for the United Kingdom, well, they've had so many resurgences, it's the graph is difficult to plot. Death rates per million population. This is again just comparing us with Australia. So here we are here. That's much earlier on, but I know that we're around about this point in this graph is a graph now, and we've certainly not had fatality rates up at this level here. We are much lower in this period of time here. So we are doing comparatively well. And I just wanted to, with this slide here, see if I can actually do it. And I don't think it can because it won't, but don't panic. I've got this. I might just have to stop sharing for a moment just to see if I can just do this, because it's very interesting. I found it interesting information.
Just while you're doing that, Jim, there's probably just one thing from your report that I do just want to emphasise, and that's your comment about 20% of us have tested positive, but our staff believe that it could be anything up to 40% who have had COVID. And so I guess I just really wanted to emphasise, particularly for the public, that it is really important that you do test, so that if you actually have got it, then you can stop the transmission by staying home. And also that you report, because as you'll see from the modelling, we really need to know what COVID looks like in our community to plan the health services. So it's really important to both test and to report so that we can do our best for our community. And Jim, I think your presentation is just, you know, a real classic, shows that it takes a village, and that's really what's happened for us. So I'll pass back to you.
Yeah, so I'm just going to, I don't know if you can you, what are you seeing there? Are you seeing some stats, or are you seeing my excess death tracking presentation again? Are you seeing
the list of countries?
Oh, perfect. Okay, so this is some data that The Economist is publishing on a regular daily basis. In fact, actually, I think, and you can link into this. But I just thought it was interesting to show. This is excess deaths, so it's a little bit in relationship to that data that I've shown you before, which is around looking at what you would expect the numbers of people to be dying in a country compared to what actually have. So many countries have, for whatever reasons, not been reporting as many deaths from COVID as other countries, and also many countries have been saying that they don't have as many cases. But this data tends to iron that out, but actually just looking at the death numbers of people who have died in those countries over the period of time. And this starts, this, as you see there, lists countries and the time period from when the pandemic started through until the current date, and reports the COVID deaths in those countries, and then the looking at the excess deaths. So those are deaths beyond what they would normally expect over that time. And then it's got these little worm graphs here on the right-hand side here, which show that the peaks in the numbers of deaths. There's the line there is deaths that you would have expected over that period of time, and the peaks are the excess deaths. And you'll see that, unfortunately for Bulgaria, in this reporting, they have the highest excess death rate per 100,000 people. So if you were to, for our own country, for instance, if you were to multiply that 1,025 by 51, you would get roughly the number of excess deaths that you would expect. And I haven't got didn't do the maths on that one, but you can see that would be quite a large number of additional people who would have died in our country if we had been in that situation. And then if you just run down that, you can see the countries there. Russia, quite large numbers of people. Coming down to some other notable, a lot of Eastern European countries there, and then coming into South America, Brazil. Still quite large numbers. There you have the United States at 346 per 100,000 additional deaths over that period of time, and their little worm graph there well above the line of excess deaths. Italy, now getting into some other more Western European countries, Greece, Spain, high rates there. Coming on down, we're getting down and still lowering at this time. There is Britain at 221, the majority rather that in their first wave there. Belgium, more Western European countries. And South American countries still heading down. We're starting to now get down to excess deaths here in this range here. There's Hong Kong coming through, and Japan down to closer to where we are, and down to breaking into positive here, or they're negative numbers, but less deaths than expected. And right at the bottom of that list there, Aotearoa, -43. So we have, over that same period of time, when you started at the top of there was 1,025 additional deaths per 100,000 people, right down through all of those countries with quite considerably large numbers to there we are at the bottom of that. So that's data up to 27th of March 2022. So about a month ago. So we would have had more in this period of time here now, but still likely that we are down in this bottom of territory and not got into in positive territory, whereas in this case negative territory. So I just thought you would be interested in that, of the efforts that we've taken as a country to be able to achieve that. These, if you do have the time, I just won't spend a lot of time on them now, but these are just this is States of America, and the quite considerable death rates that they had in the various parts, European countries, and coming through Central Europe, Western Europe, etc., right down Latin America, down to we're going to be here coming up soon there, New Zealand, there, where we have spent a lot of our time around that 0 or below 0 mark. So interesting information. And then finally, I think I just had another couple of slides, and then I'll let you.
Jim, can I just ask that that quite marked dip in New Zealand in, I think it was 20, was that probably related to no traffic accidents, people not out climbing mountains and swimming in oceans and that kind of thing?
Lockdown, and also lower numbers of people died from other diseases like influenza that year as well, because we were at home, and our residential care facilities were locked down as well, so people weren't going in there, and elderly people were not dying over the winter months as the normal pattern is. Yeah, so the only other slide I just had was just around around the vaccinations, and we've talked a little bit about the fact that the rate of those has slowed up considerably, but we do have still a proportion of the population that would definitely benefit from vaccination. Our rates around Māori, while they are not up to the 90% mark there, I can say that we do compare very favourably. Our 5 to 11-year-olds for Māori are we're the third best in the country around 5 to 11-year-old vaccination. So definitely strong support from within our community for Māori to have their children protected, and aided very much by the work that both Ngāti Porou Hauora and Tūranga Health have done to make sure that vaccinations are available in communities. That's me. Oh, I do have one other thing I really neglected to say before, which is that tomorrow is World Clerical and Administration Day, and we have got a celebration of that planned for our teams here that provide those services within our organisation. But just wanted to highlight the value of the work that is done by admin and clerical teams, the fact that we're very much going to recognise that this year with that day recognised, and of course their pay equity settlement is going up for ratification shortly, so hopefully that will be supported, in those new rates that remove sex-based undervaluation of that work will be in place very, very soon.
Thank you, Jim. And can you stop screen sharing so I can see around? Great, thanks. Andy.
Yeah, thanks for that, Jim. Just curious, are you aware of any analysis of understanding of the drivers of severity? You seemingly get a big group of equally healthy people. Just had it go through our own family, and some people get it really bad and some people get it really mild. Is there any analysis of that, why that might happen?
I haven't seen what that. I absolutely know what you're talking about, because I've heard that a lot, and it is very difficult to predict how people will respond. But I haven't seen anything that actually says what those factors are, beyond the fact that people with underlying health conditions are more likely generally to be more affected by the virus. But there's some very fit and healthy people who have, I think, been very surprised themselves at how badly they've been affected.
Thanks.
Does anyone else have any questions? No. I did just really want to underscore the comments that have been made about Takatū Hub and it being held up as a model, not just locally but around the country. So I think that's a real, real mark for those people who have put it together and worked together and continued to provide services and care through the hub. Okay, we will now move on to our next item, which is at page 40. It's the policy review on the disclosure of interests and conflicts of interest. So this arose from a review by internal audit, and they have also signed off on what actions have been taken. So Jim, is this you that's presenting this to us?
Yes, I do want to, though, absolutely, and she's on the line as well, give absolute credit to Rachel for doing the huge amount of work on this to actually be able to get this and to work with Jana as well to be able to get this into a position that we can present that to you. Rachel also did do this little cover paper for you that explains where it came from and the fact that we have also included the requirements from the Public Service Commission. If you remember, they came out with some updated requirements around this, so we're able to put everything together and present this revised policy for your review and hopefully approval.
Very good. So this is a decision item. Is that right?
Yes, it is.
Okay. Does anyone have any comments on the revised policy? No. Oh, Rob.
Just to say, this is a great policy. I'd just like to congratulate the staff. It's been a while. So I think this has been sitting on our list for a while, and thank everybody for getting it done. Kia ora.
Hello.
And I guess this is part of that push that we're having to try and get as much as we can done before we pass over. And there's been a huge amount of work done on internal audit recommendations, and FRAC is seeing that coming through to it quite regularly. So Rob, I guess that you'd be quite keen to move this recommendation then?
Yes, thank you.
Kapai had all in favour? Very good, thank you. And thank you for your work on that, Rachel. So that brings an end to our public session. I'd like to thank members of the public who have joined us today, and any members of the media as well. And we will look forward to seeing you in May. We are fingers crossed anticipating that we may be in person in May. Our presence in the building is really down to an operational decision about what kind of risk we as a board might pose to landing all together with all of our corporate staff all at once. So it's I'm hopeful that